Okay. Are we on? Okay. Colonel Asmat, can you hear me, sir? Sorry, Brigadier Asmat. Yes. Thank you very much.
Yeah, yeah, I can hear you
Okay, Brigadier
loud and
Asmat,
clear.
this is Dr. Asim Javed here. I'm moderating the session. And I've got a panel of experts here, which is Professor Mansoor, Professor Amir Hamid, Professor Ashraf Dar, and Brigadier Kasser. And we've got an audience here. So what do you have for us today, sir?
Hi, guys. Good morning to all of you. So actually, we have done the case. We waited, and then we had to do a laser, which we successfully did. So in lab, along with me is Professor Jaswinder Singh Gill, who is proctoring this case for us. So this is a gentleman who is 82 years of age, who previously had a bypass done and had a pacemaker implanted about 2 years ago. Unfortunately, the pocket got infected and we had to explant the device. So today we brought him onto the table, and I can show you the first slide. Wapas, Pehli wali. So if you can see right there in front of you, so that's a dual chamber pacemaker. We have a temporary wire from the groin, and then we have a super stiff wire from the groin as well. So it would be just in case of any SVC tear or rupture, we can put up a balloon, bridge occlusion balloon if required. So then, next. So this was the atrial lead, which we negotiated first, put up a LLD lead locking device, and there's a laser sheath on top of it, 16 French laser sheath, glide light. And as you can see, its laser is being done, and so it's going through the axillary vein up to the subclavian vein. Next. So when it is difficult to manipulate, the outer sheath is also used as a tool to push and make the way. So as you can see, the lead is slightly, it's almost being pulled. Next, and next, and that's it. So that was the first lead, which was the atrial lead. Next. Now we deployed the same thing on the second lead, which is the ventricular lead. So an LLD locking stylet, lead locking device in.
Brigadier Asmat,
On
there's a
top of
question
it is the
in
glide
between.
light.
Brigadier Asmat, can you take a question
Yeah.
now at this moment, please?
Just let me finish this, and then if you allow me, we can.
Okay.
Is that all right? Just one more picture, actually.
Sure. Go ahead, please.
So negotiating the bend here, and as you can see, next, the glide light sheath. This is 16 French glide light sheath, the laser sheath. Next. That was the. Yeah, you can almost see the lead is about to be taken out. Next. Yeah, and so both the leads were successfully explanted with help of laser. So
Excellent.
Yeah. Any question, please?
Yeah. Go on, please.
Jazz ko bhi ab. Yeah. Well, Jazz would like to take any questions if you have.
Yeah, Azmat, can you hear me?
Yeah, I can hear you very loud and clear.
Okay. So my
over to Jazz now.
Professor Amir, he wants to shift the mic to Dr. Singh, and he's then going to take your questions.
So when was this device was implanted? How long it was implanted there?
I think they can't hear us right now.
But I think this is really a great thing. I remember many years ago, infections were commoner. The leads were not so good. Fracture of the leads was quite common in those days, and we didn't know what to do about it. There were different techniques people deployed, but they were all full of risk. And most of the time, we used to leave those leads right
Jazz,
there.
can you hear us?
Okay. Hi, Dr. Jaswinder.
Yes, I can hear you. Yes.
Can you hear me loud?
Yeah.
Okay, thank you very much.
So, yes, I can hear you.
How old were these leads?
How old were these leads, Dr. Saab?
These leads are just under 2 years old.
3
But
years?
you can see that, you know, when under 2 years old, just under,
Under
2
2 years
years.
old.
But when we tug the leads, when we pull the leads, the lead moves a little bit, but it doesn't move very much.
Okay.
And that suggests that it's bound in. And you could see that when we actually did the laser sheets halted at different places.
Okay.
And we had to take quite a lot of time to try and just loosen up those areas so that the lead would move freely and then come out. So even a year-old lead or a 2-year-old lead can be quite badly bound in by fibrosis, and it really depends on the nature of the individual as to whether these leads get fibrosed or whether they stay relatively free within the system. And you can be surprised that even trying to take out a year-old lead can be really difficult.
So could it be the result of cabbage or some other, like some fibrosis?
No. It's the way the healing process occurs. If the individual is one of these guys who heals very avidly, then these leads will cause a reaction within the vasculature and cause the thing to fibrose in the wall.
Okay.
If you have a gentleman who is not got much of a fibrotic response, then the leads will remain relatively. And so, despite the general theory is that the longer the lead remains in, the harder it is to take the lead out. But even these quite young leads can be quite difficult to remove.
Okay, good. Thank you very much.
A little wayward question, this. What will you do if you have to extract a leadless pacemaker? Would you...
You have to go in there and grab them. Yeah. Those are really difficult. The tendency is now to just, you know, there are leadless pacemakers which displace. And then the idea is that you put a snare down the back end of the leadless pacemaker and take it out. But what people have done nowadays is if a leadless pacemaker becomes defunct or doesn't work, then they just leave it in place and put a new one in. So you have more and more hardware actually sitting inside your heart in these situations.
So does that increase your weight?
Yeah, I think it's a great way of gaining weight.
Just one thing. This is a 2 years old lead, and I see that your laser guiding sheath has not gone too deep. So you've just taken the area over the clavicle, under the clavicle over the first rib.
What we've done is we've just released the fibrosis at the top end, which is holding the lead in. The lead actually further down is not being held in by the fibrosis.
Yeah.
So once we were able to release the top bits of the fibrosis, the whole lead moved very easily and came out.
Did you do an
Whereas if we were trying
angiogram
to
from the
just-
left side? To see
We haven't done an angiogram from the left-hand side, so I don't know whether the lead is occluded or not occluded. And if we
My
were intending to
question is,
leave,
a lot of times, so there are different techniques. A lot of us make a pocket first and then go to the muscular level and then, you know, go take the axillary. Others would go through the skin first, and I've noticed a lot of times the skin technique, you go right under the clavicle, and a lot of times you can lift the periosteum or the very harsh ligaments over there, you go through those dilating. So actually that
you don't
can
want
fix
to do
the
that
lead also.
because if you do that, you end up with the lead being really bound to the clavicle, and it's then very, very difficult to take out because the laser won't go through bone.
Yeah.
So if you have that, then you end up in the situation that you have to really surgically remove these leads. You have to go down below and then pull the lead out below, having cut the lead at the top. So the access technique and the implantation technique at the beginning is very critical to what sort of problems you have in the future. So it's important that when we train people to actually put these things in well. We'd use axillary punctures, not going into the subclavian if we can help it, so that we're well away from being able to bind these leads to the periosteum of the clavicle.
Yeah. Could you unscrew the leads? Because I see that they are not tying leads, they are screw-in leads.
Yeah, these are screw-in leads. So what we do at the beginning, and I think we weren't able to show you this. We release the whole lead so we can open the lead up.
Okay.
And then at the end we put a Spencer Wells and then we unscrew the screw. And 50% of the time the screw will come back, but another 50% of the time it won't come back, and you have to just release the screw from the endocardium. But these screws are not really very tightly screwed in, and so it's actually not difficult. A tined lead is much more difficult to release from the myocardium because you tend to get the area fibrosed right at the tip. And also, almost always, when you take a tined lead out, you take a little blob of myocardial tissue out with it.
So generally, for the audience, Jess, where would you recommend the leads to be extracted, in a hybrid lab, in a OR, or in the cath lab?
I think I certainly think that any place which does extraction, I think, needs surgical facilities. That's number one. And the best place to extract these leads, I think, is a hybrid theatre where you have a surgeon on standby and you have full facilities for inducing cardiopulmonary bypass. Because I think if you're trying to do these in the cath lab situation, the surgeons are not very happy. Very occasionally, just in one in 50 to 100 cases, you're going to have to open up the chest in order to actually get these leads sorted out, because you have a tear in the SVC, or you have a tear in the atrial appendage, or in the body of the atrium, when you're actually trying to extract these leads. And if you do so, you need very urgent opening of the chest and the surgeon to actually put a stitch in where the hole is. And so I think these are ideally done either in an OR where the surgeon is ready with you and you have a C-arm to actually help you, or the ideal place really is a hybrid theatre. And I think the development of hybrid theatre in Pakistan really for this sort of service is very, very important.
Yeah.
Can I ask you about your laser generator? Is it the same laser generator, or could this be used for coronaries that Sohail did earlier?
No, it's the coronary. It's the same one as the coronary.
It's the same, okay.
In fact, the team have just done a coronary case with it. Sorry, I'm just going to let Brigadier Azmat in here because he wants to have a word. So can I just pass the mic to Brigadier Azmat, please?
Thank you very much,
Guys,
Doctor.
hello.
Yes, Doctor.
Just one more minute, please.
Yes, Dr. Azmat, you want to make a
can you hear
final
me?
comment?
No, I think we are done with that. So I just want to show you one thing more, because we have done two cases. So one was a laser case, and the second one was an arrhythmia mapping system, use of arrhythmia mapping system. So we actually were to show you two cases. So I'll just again show you the pre-recorded images. As you can clearly see, there is a right-sided right atrium geometry. It was a right-sided flutter, and we ablated this flutter with the help of arrhythmia mapping system. You want me to show the... Yeah.
Wonderful, we can see that. Looks beautiful.
Yeah, can you see that?
Yes, we can see that.
Yeah, so this is, as you can see, there's the propagation moves in the clockwise, the anti-clockwise direction. Yeah, as you can see that.
We can see that.
Yeah, and can we show after ablation? Okay. So this is pre-ablation, and once we ablated the cavotricuspid isthmus, we draw a line along with the isthmus. I will try to show you these are the ablation dots, the spots ablation, and
It looks like there is some gaps still there.
yeah, there were actually some, and then we had to go in and ablate again. You're absolutely right, spot on, to be honest.
So excellent job, excellent.
And I'll
Very
try
good.
to, yeah, I'll
You're
just
great.
just
You are
show
doing
you
great
the last
job.
one. It's a
Azmat, excellent laser and this all type of mapping systems. You people are doing great.
thank you, sir. Thank you so much.
Azmat, could you get a
Sir?
bidirectional block on the conventional system? Did you check for it?
Yeah, we did. Yeah, we did, got it, we checked for it. By the way, these are the images post-ablation after even sorting out that gap. Because gap was down below, just the IBC end. Can you run it? Yeah.
But now it seems to be blocked.
Yes.
Yeah,
yes.
that's right.
Yeah.
Thank you so much, guys. Thank you so much. I won't
Thank you
take
very much,
more
Brigadier
of your
Azmat, and
time.
thank
I
you,
know
Dr. Gill, for an
short
excellent
on time.
demonstration.